Good evening, everyone. My name is Agina Francis Makwabe. I'm the consultant nephrologist and physician working with the Africa Healthcare Network in Tanzania. I would like to welcome you all into today's AHN Nephrology Education webinar. Today is a great honor to introduce to you our today's speaker, Dr. Abhijit Konnur, a consultant nephrologist at Muljibhai Patel Urological Hospital in India. So Dr. Abhijit had got his MD at Vadodara Medical College in Vadodara in 2004, and DNB Nephrology in MPUH in the year 2009. He did his nephrology at nephrology in adult nephrology and renal transplantation at University of Toronto, Canada in the year 2015, and worked in Fortis Memorial Research Institute at Guggen and Columbia Asia Hospital, Guggen, as a consultant nephrologist. So it's a great honor to welcome you, Dr. Abhijit, and you are warmly welcome for today's topic, which is an approach to glomerular disease. You are warmly welcome, Dr. Abhijit.
Okay. Thank you, Doctor, for this very warm and kind words. And at the outset, let me thank the African Health Network, Dr. Vincent Lloyd, and all my co-panelists for giving me this opportunity to be able to connect to all of you. And I am going to speak for close to 45 minutes on a topic which is very passionate, which I'm very passionate about. It is an approach to glomerular disease. And I hope you enjoy. And it's an interactive presentation with some clinical vignettes in the end, which I'm sure you all will help, enjoy solving. So without much ado, I hope my slides are visible.
Yeah, just to make it full. Yes, full. Very clear. Thank you.
Right. And I'm audible, right? So I can start off, sir?
Yes, sir. Yes, sir. You can start.
Okay. So as we all know, this is the normal structure of a glomerulus, and it typically consists of the capillary loops that you see here. And these are covered by interdigitating foot processes, which are the extensions of this primary visceral epithelial cell called podocyte. And in between them, they is to rest on the glomerular basement membrane. These capillaries are held together by a specialized macrophages called mesangial cells, which have some amount of area around them called mesangial matrix, which is like the cementing substance which holds this whole bunch of capillaries together. Now, let us consider these two diverse glomerular diseases. One is a 24-year-old female who presents with rash over cheek, symmetrical small joint, appendicular polyarthritis, and painless oral ulcers, decreased urine output, hypertension, cola-colored urine, puffy face, and the urine shows subnephrotic range proteinuria, dysmorphic RBCs, and RBC casts. And on the other hand, we have a 4-year-old male who presents to us with a sudden onset puffy face and pedal edema, decreased urine output, who's normotensive, who complains of foamy urine, is anasarchic, and his urine shows nephrotic range proteinuria and no sediments. So these both are two ends of the spectrum of glomerular disease, as we know. And this is actually the holy grail of glomerular disease. Essentially, if the disease involves injury to the podocytes, it leads to scarring, deposition of matrix, and this typically presents with proteinuria. And these typically are in the left-hand side, and they are minimal change nephropathy, FSGS, membranous nephropathy, and amyloid. The diabetic nephropathy also forms the commonest cause of nephrotic syndrome in the world as of today. And on the right hand side, as we go, this involves the capillaries. So diseases involving the capillary where there's inflammation, reactive cell proliferation, breaks in glomerular basement membrane, and crescent formation from the other end of the spectrum, where you have post-streptococcal glomerulonephritis, small vessel vasculitis, and anti-GBM disease as the hallmarks of this disease. There are two diseases which extend throughout the spectrum. That is, one is lupus nephritis, which can extend anywhere from minimal change disease to anti-GBM disease. And the second is IgA nephropathy, which typically involves hematuria rather than proteinuria, but can also have proteinuria. One should be clear about the syndromes of glomerular disease when one is dealing with glomerular disease. So the glomerular disease can present with isolated hematuria, and this typically points towards diseases associated with the glomerular basement membrane. One can have isolated proteinuria, which is essentially functional disease of protein uptake in the tubules actually. Acute glomerulonephritis, which is inflammation of this whole glomerular structure. Nephrotic syndrome, which denotes disease involving the podocytes, and thrombotic microangiopathy, which involve disease involving the vasculature or the capillaries. Nephrotic syndrome is defined as presentation with decreased urine output, hypertension. Nephritic syndrome is typically defined as presenting with decreased urine output, hypertension, puffy face and pedal edema, cola-colored urine in the form of hematuria, RBC casts on microscopy, and a urine protein which is subnephrotic range. And nephrotic syndrome is typically presenting as urine output more than 3.5 grams per day, presence of hypoalbuminemia, puffy face and pedal edema, foamy urines with no active sediments, and presence of hypercholesterolemia. Some things to know about hows and whys of glomerular disease. So how does the glomerular disease occur? If there is proliferation, meaning there is increased amount of cells than are usually present, this can either be endocapillary or extracapillary. Endocapillary is by means of something involving the capillary loops. So inside the capillaries. So these can be external cells like neutrophils, lymphocytes, and plasma cells, and extracapillary, which is outside the capillary, which may be mesangium, the visceral epithelium, or glomerular basement membrane. Proliferation of anything, nomenclature is either endocapillary or extracapillary. The second is, why does this occur? So typically it involves immune complex formation or deposition. If the antigen is present in the glomerular basement membrane, like the anti-GBM disease, it can be involving circulating antibodies which get deposited on the glomerulus, like in membranous nephropathy, where you have PLA2R receptor antibodies that are present. And lastly, you can have circulating immune complexes which get deposited in the glomerulus, like in lupus nephritis. And any of this deposition kickstarts the activation of complements, which and they have chemokines like C3A, C5A, and you have cytokine release, which leads to ingress of neutrophils, macrophages, recruitment and activation, and finally activation of the coagulation system. So can we get a clue based on what we get clinically to help us know where actually the problem might be? So if it is subepithelial immune complexes, subepithelial meaning just below the epithelium, that is the podocytes, usually they present with less of inflammation. There is podocyte damage that occurs, and clinically they will present with proteinuria. If the immune deposits occur just below the capillary, they will, like here, then you will have more inflammation and cellular proliferation. There is vascular damage that occurs, and they present with hematuria. And somewhere in between, where that is means the glomerular basement membrane, if the immune deposition is there, they can either present with hematuria or proteinuria and or both. Sometimes the damage to the glomerulus may not be immune mediated and may be due to direct cell toxicity. This can occur in diseases like ANCA vasculitis, where there may be epithelial cell injury and loss of foot process, effacement of basement membrane and proteinuria, or it may be due to primary activation of complement, like that occurs in membranoproliferative GN or C3 nephritis. How does the glomerulus respond to injury? This is very important to know, because in the end, the outcome of glomerular disease depends on this. So initially, you have increased amount of cells that come rushing into the glomerulus. So these are seen in the inflammatory states, and there is proliferation of either the local mesangial cells, which are the modified macrophages, or the endothelial cells. And there is inflammatory cells like the lymphocytes and the neutrophils that come rushing into the glomerulus. And there may be proliferation of epithelial cells. If the inflammation is very strong, then there is breakage of the capillaries and there is leak of plasma that occurs into the Bowman's space, urinary space. And this actually irritates the epithelial cells to produce hypertrophy of the visceral epithelial cells, and also ingress of macrophages, which typically leads to crescent formation. Then over a period of time, there is hyalinization or increased deposition of matrix or connective tissue, which is like a pink homogeneous material. And there is this plasma proteins deposit there. And eventually, this leads to change of the cells to fibrosis by fibroblasts. And there is increased basement membrane, which leads to thickening of the capillary loops and the increased immune deposits. Now, all of us usually get confused about the nomenclature of glomerular disease, but I have tried to simplify this, and one just has to focus on the glomerular histology. All glomerular disease require a biopsy. So without a biopsy, delineating a glomerular disease is very difficult. So one would focus on the biopsy, and this is the scanner view on the right-hand side. So the first question to be asked is, how many of these glomeruli are involved? If it is only some glomeruli, then the nomenclature is focal. If majority of the glomeruli are affected, then it is diffuse. Now, focusing on to a single glomerulus, one asks the question, is the entire glomerulus involved? If the answer is yes, then the nomenclature is global. And if only a part of the glomerulus is involved, then it is called segmental. And the next question is more of clinical. That is the renal disease isolated to the kidney, or it is part of a systemic disease, which delineates it from being primary or secondary. A clinical approach is very important. One has to make up one's mind about the clinical syndrome so that one is able to form a concrete diagnosis. So approach to glomerular disease has these 4 steps. Step 1 is urinalysis, or evaluating the liquid gold. That is to confirm the degree of proteinuria and also confirm the presence or absence of active urine sediments like dysmorphic RBCs or RBC casts. Step 2 is confirm with serology. So find out if what's happening to the complement levels, whether this complement level C3, C4 or CH50 are affected, and also send off a extended ANA profile, send off ANA, ANCA, anti-GBM, Pla2Rs, factor H antibody levels wherever required. Third is to conduct a renal biopsy. A renal biopsy typically has 3 readings. One is the light microscopy, second is the immunofluorescence, and third is to use special stains like Congo red, Pla2Rs, amyloid A antigen stains. And for some of those which require special looks, to send for a specialist electron microscopy. And wherever necessary, also to order genetic testing, which is now increasingly being used, like patients where we suspect congenital nephrotic syndrome or Alport syndrome or atypical hemolytic urinemic syndrome. Classification of glomerular disease can be in various ways. So it can be primary or secondary. So typically the primary glomerular disease are membranous nephropathy, membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, IgA nephropathy, or secondary, meaning secondary to some disease which has occurred elsewhere in the body, like post-streptococcal glomerulonephritis, TTP-HUS, thrombotic microangiopathy syndromes, anti-GBM disease, which can involve the kidney and the lungs, vasculitis, which involves various parts of the body, and lupus nephritis, which involves, again, is a systemic disease, of which the kidney is an important part in 50% of the presentations. Presence of nephritic or nephrotic syndrome, depending on what we discussed earlier. Presence of proliferation that is present in the histology. Immune complex or quasi-immune based on the immunofluorescence, whether it lights up or not. If there are presence of crescents, crescentic GN or non-crescentic GN. And lastly, presence of endocapillary or extracapillary GN based on the cells that are present in the glomerulus, whether they are localized to the cells in the glomerulus or they come from outside. So glomerular disease associated with nephritic syndrome are primary or secondary. Those associated with nephritic syndrome are either post-infectious or diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis, mesangioproliferative glomerulonephritis, and crescentic GN. I want to draw everybody's attention to the proliferation that is occurring here. That means the increased number of cells. In the post-infectious or diffuse proliferative, they are essentially dealing with the cells which are coming from outside the glomerulus. Second is presence of membrano, meaning the membrane cells, the amount of basement membrane increases. Third is IgA nephropathy or mesangioproliferative, meaning the mesangial cells are proliferating. And lastly, crescentic GN means there's an extracapillary proliferation of cells in the Bowman's capsule or in the urinary space. And secondary to diseases like Henoch-Schönlein purpura, systemic vasculitis, lupus, or systemic sclerosis. Again, a differentiation of nephrotic syndrome typically can be involving primary glomerular disease or a part of systemic disease. The primary glomerular disease differential usually is membranous minimal change disease, focal segmental glomerulosclerosis, and amyloid. Membranoproliferative and IgA nephropathy sometimes, rarely, can be causes of pure nephrotic syndromes. In the systemic disease, you have diabetes mellitus, which is the commonest cause of nephrotic syndrome all over the world as of today, and also amyloid, lupus, some drugs, malignancies, infections, and miscellaneous. As discussed earlier, glomerulonephritis is typically a syndrome which is characterized by hypertension, oliguria, proteinuria, hematuria, dysmorphic RBCs in urine, and RBC casts in the urine. Because dysmorphic RBC and RBC casts are the pathognomonic features of glomerulonephritis, you see even one, you know you're dealing with glomerulonephritis. It's important for us to know how they look. So on the right-hand side in the cartoon, you can see these various types of dysmorphic RBCs. Dysmorphic RBCs typically require phase contrast microscopy of the urine. And the classical one is the one on number 9, acanthocytes, which is also known as Mickey Mouse ears presentation. And it presents as vesicle-shaped protrusions or blebs, if you may say so, out of the RBCs. And the presence of RBC cast, as one can see, this is from one of my patients. So I can confirm that this is a RBC cast. The acanthocytes or the dysmorphic RBCs flow down from the, they are excluded through the glomerulus, through the fenestration slits that are present in the glomerulus, and they come into the urinary space, and then they are thrown into the tubule, where they pass through the tubule and they're subjected to marked changes in osmolality, ionic strengths, differences in pH, and other forces. And finally, they lodge on to the TAM phosphol protein to form the RBC cast. Acute GN presents typically over days and presents with oliguria, edema, hypertension, hematuria, RBC casts, and proteinuria, which is subnephrotic range. A classical example is post-streptococcal glomerulonephritis. Whereas chronic glomerulonephritis usually have been present for more than 3 months, and they present with hypertension, renal dysfunction, a proteinuria which may be in the nephrotic range, but they also have shrunk smooth kidneys on ultrasounds. And lastly, you have the third category called rapidly progressive proliferative glomerulonephritis, which present over days to weeks. Usually no hypertension is present. They are associated with systemic signs of vasculitis. Proteinuria is typically subnephrotic range, and one may find hematuria and RBC casts on urine exam. Another important slide, important for all of us, especially our emerge nephrologist or somebody dealing with acute nephrology, how to differentiate glomerular hematuria and urologic hematuria. I will quickly go through the salient points. Glomerular hematuria is presents typically with altered urine color like coffee or tea or brown, cola colored. You can call all of that. Whereas urologic hematuria is bright red. You have serpiginous clots that are present in urologic hematuria. Proteinuria is typically present with glomerular hematuria. You'll get dysmorphic RBCs in glomerular hematuria, and you'll also get presence of hypertension, edema, and history of upper respiratory tract infections in glomerular hematuria. Whereas there will be voiding symptoms, there will be flank pain, and the renal function will be typically normal in the urology causes of hematuria. This is an important slide. One usually doesn't get this information. I have tried to collate it as to understanding when we send samples for serology. Does that give us a clue about what could be the underlying glomerulonephritis we are dealing with? So when we send for complement levels and there are depressed all complements like C3, C4, the C3 stands for alternative complement pathway, C4 for the classical complement pathway, and the CH50 is for the common complement pathway. When all of these are depressed, one is dealing with lupus nephritis, cryoglobulinemia, or maybe membranoproliferative glomerulonephritis. If you have depression of only the alternate complement pathway like the C3 with a normal C4 and depressed CH50, one is probably dealing with C3 glomerulonephritis. And it can also be found in non-glomerular disease like atherosclerotic renal disease, endocarditis, and shunt nephritis. If you have depressed factor H antibodies or presence of factor H antibodies, then one is dealing with thrombotic microangiopathy. And if there's a production defect in factor H, one may be dealing with dense deposit disease or with lupus nephritis. This may also be associated with liver disease or malnutrition because of non-production of this and of the complement system. So investigation of glomerular disease, as I said earlier, requires a renal biopsy. What does one look out for? So in the light microscopy section, first focus on the glomerulus. Try to find out which cells have increased or have they increased at all. Look out for hypercellularity. Look out for increased matrix deposition, and look out for thickened basement membrane. And At the same time, then look around the glomerulus to the tubules if there is presence of tubular atrophy and fibrosis, because in the end, the longevity of the kidney depends on this and not only the glomerulus. And lastly, look around for the changes that occur in the vessel. If they suggest hypertensive changes, like there is a thickening of the intima or the adventitia or the media of the cell, and there is necrosis of the cell wall or of the vessel wall, which will suggest vasculitis. The next part of the biopsy is the immunofluorescence. So focus on which immune complex gets deposited, where does it get deposit, and how does it deposit. So usually which are stained are the IgG, IgA, IgM, and they may go and sit on the glomerular basement membrane or in the mesangium, and the deposition patterns may either be linear or granular. And lastly, in some of those special cases, we definitely wants to look out for changes in podocytes, basement membrane, and mesangium. Now, electron microscopy is extremely important for us to find out those rare causes of steroid-resistant nephrotic syndromes, or those ones which usually we don't get a clue, or which are not, or where we are not able to understand what is the final diagnosis, like fibrin deposition, fibronectin nephropathy, collagen vascular disease. These rare types of glomerulonephritis cannot be diagnosed without an electron microscopy. So in those cases which are not responding to therapy as one would want them to, they should be subjected to electron microscopy. Now coming to the interesting part of clinical vignettes and learning something from them. So I have around 7 cases, so we'll breeze through them. I will pause at the differentials where you can mentally try to make out your differentials, and then we'll see what it turns out to be. So case 1 is a 20-year-old female who presents to us with puffy face and pedal edema, which progressed to NSRCA over 4 days. There's decreased urine output. So no hematuria, no history of cola-colored urine. She was normotensive and anosartic. Her urine dipstick showed 4+ for protein, 18 grams of protein in 24-hour collection, no active sediments. Serology, normal C3, C4, and the ANA was negative. So here, from what we learned from the previous slides, you can clearly say we are dealing with a nephrotic syndrome, an adult onset nephrotic syndrome. So differentials, we can put minimal change disease, focal and segmental glomerulosclerosis, and membranous nephropathy being the usual ones. Now let's go and see what we see. So this is the scanner view, HNE of her biopsy. And one can see that the tubules are back to back, and focusing on the glomerulus. Well, nothing looks abnormal from this. There's not too much of cells there. The capillaries look patent. So let's go to a more magnification. This is 10x, 50x magnification. Again, focusing on the various parts. So mesangium, not too much of hypercellularity. If I can just point out, these are the mesangial cells. These are the capillary loops, and they are patent. And the basement membrane between them doesn't look very thickened. There's nothing outside to suggest any crescents or any other cells. There's nothing inside to suggest any cells which have come from outside. So there is really nothing really abnormal with this glomerulus. Now, this is the silver stain, and each stain has some peculiarity, and I've taken them to point those things out. So the silver stain actually will help us point out if there are any immune deposits that one can see, and also to look out for thickening between the basement membrane. So here you don't see any thickening that has occurred. And so we in fact sent her for a slide because she's 20 years old for an electron microscopy. And I want everybody to focus on these two. This is the normal, just to understand what is abnormal. So the normal here, these are the foot processes that one sees. This is the glomerular basement membrane. This whole thing inside is the capillary, and this is a big RBC sitting in the capillary. This is the endothelial cell nucleus. And here this is a normal glomerulus. Now let's see what's happening to this disease glomerulus. One can see that the food processes have turned into lumpy bits. There is nothing abnormal that one sees in the basement membrane. There are no breaks here. And there's nothing abnormal that one sees in the endothelium here. So probably we are dealing with minimal change disease. And that's how she was diagnosed. And she was treated with 6 weeks of steroids given at 2 mg per kg. And she attained remission after 15 days with proteinuria becoming nil and slow taper of the steroids over a period of 2 to 3 months. Case number 2 is about a 14-year-old male who presented to us with sore throat, which was there 2 weeks ago. And now he has puffy face, pedal edema, reduced urine outputs, and cola-colored urines in the last 3 days. He's also found to be hypertensive in the emerge. His urinalysis shows a proteinuria, which is 1.6 grams per day. And he does have RBC in the urine and casts that are present. His serology, which was sent, also turned out to be anti-streptolysin O titer, which was elevated. And his C3 levels were depressed. So here we are typically dealing with a young boy with a past history of sore throat and now presents to us with oliguria and hematuria and altered urine and hypertension. So this is a glomerulonephritis. There's inflammation here. There is proliferation that one would be able to see on histology. So tentative diagnosis of proliferative GN was kept for this young boy. And now this is a scanner view. It is a hematoxylin eosin stain that was used. And one can immediately say that the glomeruli are not normal. The number of cells in these glomeruli are huge. So this is proliferative GN. Now, next thing is to focus on the glomeruli itself. This is not the common stain used to see glomeruli, but I wanted to point out some things. This is a Masson trichrome stain. So we focus on to the glomerulus and we can see that the capillary loops, they don't look really patent. And you have some cells which are multinucleated and they are neutrophils and they have appeared new. The mesangial cells, meanwhile, the numbers look same, but there is definitely endocapillary hypercellularity that has occurred. And now this is the past stain, and I want everybody to focus on these few unusual looking cells here. So this is a bilobe neutrophil that one can see. Similarly here, all these atypical here. So these are inflammatory cells that have come in. Now a large part of the capillary lumina are also clogged with these cells. And the number of cells in the glomerulus itself is increased. So this is endocapillary hypercellularity that one is seeing. So one can say that this is proliferative GN with endocapillary proliferative GN. And now trying to find out what are those things that made it proliferate. So IgG lights up, and you also have C3 complement lighting up here. And when this was sent for electron microscopy, again, from the previous slides, this is the glomerular basement membrane. These were supposed to be the healthy podocytes, which are now completely effaced out. And this is the capillary side. And you have the endothelial cell and the nucleus. This is RBC. And you can see these black humps that occur. So these are subepithelial humps. The podocyte is also called a epithelial cell. So subepithelial humps typically seen in anti-streptococcal or post-infectious glomerulonephritis. And his treatment was basically, it's a self-limiting disease. We gave him some small diuretics for his hypertension and advised salt and water restriction. And his blood pressure came under control and he had an excellent recovery as one expects it to be. Case number 3 is about a 65-year-old male who presented with insidious onset swelling all over the body over the 4 months. He had preserved urine outputs, no hematuria on history. He was normotensive, anasartic. Urinalysis showed 24-hour urine protein of 20 grams and no active sediments. Serology, normal complement levels, but an abnormal test, that's a Plato-R antibody titers came elevated. So that should give us a clue. Plato-R levels elevated. This is very specific. There's nearly 100% specificity for membranous nephropathy. So what are we dealing with here? So this, I'm immediately going on to the glomerular high magnification view. This is a hematoxylin eosin stain, and one can see that let's see the various compartments of the glomerulus. One is the capillaries. They are all patent, so no problems there. Mesangium, the mesangial cells are normal. Usually 3 or more cells are considered abnormal. Here you usually have 2 or 3 cells in the mesangium. Not too much of efforts going on there. But yes, the basement membrane appears slightly thickened here, and more so here. There are some areas here where you find thickened. There are no atypical cells one sees like neutrophils which are coming in. So here the disease probably has something to do with the basement membrane. And this is again another view of another glomerulus. And here one can in fact make out that the basement membrane is thickened. How does one know that? One actually compares the thickness of this to the tubular epithelium, the tubular basement membrane. So if you compare this and this, basement membrane here is thick as compared to this. So there is thickening of the glomerular basement membrane. Now this is a silver stain. And the reason to show this is it's very well done. And one can actually see that there are holes that are present in the basement. These are pin cushion view, or there are pin-like holes that are present in the basement membrane. These are actually where the electron deposits have been washed away because of the processing, and you have holes that are present in the glomerular basement membrane. And when one increases the magnification, one can see these spikes that are so classical of membranous nephropathy, right? So this is the spikes that are present. And as I had mentioned earlier, this is a cheap way or a very good way of looking for electron-dense deposits is the Masson trichome stain, where one can actually see these deposits as red deposits that are present in these ones that are present in the basement membrane. So if you look hard enough, you can see them. Now IgG and C3 light up, and C3 lights up very strongly as compared to IgG. And this is the specific stain used for Plato-R. They light up along the glomerular basement membrane. So this is Plato-R positive membranous nephropathy. What do we do with these patients? Usually, if they are having a minimum amount of proteinuria, or there is no real renal failure, then one could wait for 6 months for spontaneous remission. At least start these patients on ACE and ARBs. In those patients who have not remitted spontaneously or are having high risk factors like significant proteinuria, like our gentleman here, one would treat them with either modified Ponticelli regimen, alternating steroid and cyclophosphamide, or start them on the mentor trial associated rituximab doses. And also consider anticoagulation if the serum albumin levels were less than 2 grams per deciliter. Case 4 is of a 16-year-old male who presents with puffy face and pidal edema, febrile illness, cola-colored urine, and oliguria, all for the last 2 months. He also has hemolytic anemia and thrombocytopenia. His LDH levels were increased, and he was sickling negative. He had hepatitis C antibody present, and his C3 was depressed with normal C4, and total CH50 was depressed. So clearly here we are dealing with a disease which is systemic in nature, where there's hemolytic anemia, and also there is a rapid loss of renal function. So we probably, with the LDH increase, so we probably could be dealing with a angiopathy. Now, these are 4 slides that I would, first is the scanner view. On the left upper side, if you'll focus on the glomeruli, they are abnormal, they are filled, they are proliferating. That's all we can say on this. On the right side, when you magnify to 50x or 100x, one actually sees that there is a lobular pattern for the proliferation, and there is proliferation of cells in the glomerulus, and they are usually more of mononuclear cells than polynuclear cells. And the capillary loops also look not really patent. And if the right upper is basically a pass stain, right lower focuses on that glomerulus from a different angle altogether. And one can say that the mesangial cells, that is the cementing cells, are not proliferating, but definitely on the right upper parts, upper sector, you actually have a significant amount of proliferation of the cells. So this is a proliferative GN. There's a lobular proliferation of this GN. Now, the next step is to understand whether any clues we can glean from what kind of proliferation we have got. Is this a capillary proliferation? No. Is this a mesangial proliferation? Not really. Is this a membranoproliferative? Yes, this is a membranoproliferative glomerulonephritis. And as one can see in the right upper and lower quadrant, you have these red splotches, meaning there is significant immune deposits that's occurred in the glomerulus and the glomerular basement membrane. And the kind of deposition is something to do with C3, because that has lit up in the immunofluorescence in the left lower segment. So the light microscopy helped us zone in on the thickened basement membrane, and there's doubling of the basement membrane on the silver stain, which you can see in the left lower. And the immunofluorescence, it lights up with C3. And this patient, his biopsy was sent for an electron microscopy. And I want everybody to focus on the type of black material or the immune deposits that are happening. Now, this is the capillary, and this is the endothelium. You can see this is the endothelial nuclei, and you have this black deposition that is occurring towards the endothelium. So subendothelial deposits. And also, this is the urinary space that one can see. And then in the lower slide, you actually have this depositing linearly. You can see it's like a strip that occurs. And this is typically seen in dense deposit disease in the glomerular basement membrane. The reason to send this patient's biopsy for an electron microscopy is if one has a dense deposit disease, there's a 90% probability of recurrence in a graft kidney, meaning after transplantation, the chances of graft failure are extremely high in these people. And that's one of the reasons for sending patients with membranoproliferative or C3GN for an electron microscopy. Now, membranoproliferative GN earlier was divided into 3 based on the whether there was immune complex deposition or whether there was complement deposition. The immune complex deposition is typically associated with autoimmune diseases, lymphomas, cryoglobulonemias, if there's proliferative glomerulonephritis or paraproteinemias. And complement deposition is typically seen with C3GN or a dense deposit disease. They form a spectrum of the same disease actually. There's a 50% progression to ESRD in these patients. Case 5 is of a 16-year-old male who presents with painless hematuria, bright red, which is bright red and no clots. They are usually episodes that occur after sore throats. There's presence of hypertension, non-oliguric, and there's no pedal edema, there's no anemia, no hemolysis, and urine shows gross hematuria. There's presence of RBC casts and dysmorphic RBCs. His complement levels were normal. His ASO titer was normal. And his ultrasound shows no stones, no urology cause for hematuria. What are we dealing with here? So again, the right-hand side gives us a scanner view. If you focus, the capillaries don't look really proliferative. I mean, the glomerulus doesn't look really proliferative. The capillary loops look patent. And in the magnified image of the glomerulus in the left lower, one sees that the mesangial cells are normal. The capillaries are normal. The capillaries are normal. There are no cells which are ingressing from outside like the neutrophils. So, but there definitely is some amount of increased amount of mesangial cells, which you can see more on these sides here, right? And even here. So more than 3 or 4 cells in the mesangium would make it some amount of proliferation. Again, a different look at this where if my pointer, yeah. So here, this actually shows mesangial cells which have proliferated out in this young gentleman. And similar on the silver stain. And the immunofluorescence actually points out to the lesion. So there is IgA, which is selectively deposited in the mesangium of these in the biopsy, along with some amount of C3. And one can see the IgA lights up stronger than the C3. So IgA deposition in the mesangium. So mesangioproliferative glomerulonephritis, secondary to IgA nephropathy. And this is characterized by episodic hematuria, as we all know, and can recur in 20 to 60% of patients post-transplant. It's the commonest cause for glomerulonephritis in adolescents, and it usually has a benign course over years. So again, what I had pointed out, I will jump to case number 6. Which is a 24-year-old female who presents with rashes over cheeks, symmetrical small appendicular joint polyarthritis, painless oral ulcers, decreased urine output, hypertension, cola-colored urine, puffy face. The urine showed a subnephrotic range proteinuria, dysmorphic RBC and RBC casts. Her serology showed depressed C3 levels and also presence of anti-nuclear antibodies and double-stranded anti-nuclear antibody, dsDNA antibodies. So she definitely has some systemic disease, but also involving the kidney. So this is a secondary glomerulonephritis. It is proliferative in nature because she has sediments in the urine. And now we'll see probably dealing in a young lady with the usual diagnosis that we all dread to think about. So here we have glomeruli, which without doubts have proliferated. They are full. Their capillary loops cannot be seen. And this is a typical glomerulus involving lupus nephritis. And as we see, here I want to force everybody to focus on a few things which decides the activity and the chronicity of the disease. So activity of the disease depends on some of the things that you see in the glomerulus. Chronicity of disease, meanwhile, depends on something you see outside the glomerulus. So the activity of the disease, if you have crescents, that is presence of more than 2 layers of epithelial parietal cells, presence of choriorrhexis that you can see, or fibrinoid necrosis of the vessel wall. These are areas where you can get fibrinoid necrosis of the vessel wall, where there's no cell and there's necrosis of the capillary wall, it's just disappeared. Then you have wire loop lesions, which are so classical of thickened wire loop lesions that are so classical of lupus nephritis. And you can also have again, this is classical of fibrinoid necrosis that occurs involving the capillary loop, and these are the wire loop lesions that are so well known. There could be presence of cellular crescents. These are all signs of activity in the disease, and usual signs of chronicity, meanwhile, are sclerosis, fibrosis, fibrous crescents, and tubular atrophy. So all of this, depending on the activity index and the chronicity index, one decides the level of immunosuppression that one has to give. And I also want to point out, this is the protein cap that one sees in the lupus nephritis lesions. Again, something to show the amount of proliferation that has occurred. This is a silver stain. And now we are looking at all these specialized stains. So IgA lights up, IgG lights up equally well, C3. So there is, so it helps us delineate disease processes with in typical glomerulonephritis. Whereas the IHC, when you are asking for, you are pointing out to the pathologist that you already have something in mind, like for example, Pla2R levels, or there is presence of the newer antibodies that you see in membranous nephropathy, where they will actually seal the diagnosis in these situations. Like I showed on that biopsy specimen for membranous nephropathy, a Pla2R positive on histology kind of confirms the diagnosis of membranous nephropathy and treatment for these people. And in the newer antigens, antibodies that one has seen, they can actually delineate what were the secondary causes of membranous nephropathy. Like, for example, if you have SEMA3B, which is usually seen in pediatric age group, you can have exostosin 1 and 2, which will delineate presence of autoimmune disease as the cause of membranous nephropathy. One can also have NEL, which delineates presence of malignancies, underlying malignancies as the cause of nephropathy. So biopsy specimen can actually lead you on to finding out a complete disease process in the patient. And the last is, what's the recommendation towards anticoagulation in patients with GN? Do we solely depend on serum albumin level or what? So again, a very interesting question. No, we have to also find out something about the patient. What is his job? What is his occupation? What is his lifestyle? Is this the first time in his life whether he has faced this? There is a online tool available, especially in terms of in membranous nephropathy, to decide whether one should start off with anticoagulation in patients, and what is the risk of developing renal vein thrombosis or systemic thrombosis. I would urge everybody to use the ISN website for this process. The website is hosted by Dr. Heather Reach, one of the luminaries in membranous nephropathy research. And as a thumb rule, but yes, I would depend on somebody whose serum albumin levels are less than 2 grams and 2 grams per deciliter to at least consider anticoagulation. I would also like to know something more about the cause of membranous nephropathy. Is he morbidly obese? What are the chances? Whether if it's a lady, whether she's taking estrogen pills, something which predisposes him or her to thrombosis, and then definitely take a call on anticoagulation. Another question is, in the absence of a biopsy, when would you consider use of steroids and immunosuppressive agents? In the absence of a biopsy, then you have to depend a lot on the urinalysis. So question number one is, what are we dealing with? If it's a nephrotic syndrome, if it's a child, you are definitely going to use steroids for steroid sensitive nephrotic syndrome. If it's a adult and there is no sediments in the urine, again, consider use of steroids, thinking it could be adult onset minimal change disease or membranous, both of which will respond to steroids. If there is a proliferative GN, like there are RBC casts and there is presence of dysmorphic RBCs that you get on urine microscopy, and there is presence of subnephrotic range proteinuria and also presence of hypertension and creatinine which has gone up, I would really think about using immunosuppressive agents in these people, especially if they have systemic diseases like which may suggest lupus. So one doesn't, if because of whatever constraints, one is unable to do biopsies, then as I said, depend on liquid gold, do a complete urinalysis, and the follow-up urine will also help you titrate the dose and decide how long you want to treat these patients. Like if after treatment, the RBCs, the proteinuria tends to resolve over 3 to 6 weeks. The RBCs tend to resolve over 6 months of immunosuppressions. And that's when you would dial down on the immunosuppressive treatment that you would give these patients. So yes, treatment is possible even without a biopsy, and we do the best we can for our patients. Next question is, how do I classify a 11-year-old who presents with steroid-resistant nephrotic syndrome and MPGN pattern after a biopsy? Normal C3, low C4, and persisting proteinuria. IF could not be done. It's a tough one. Here, a normal C3, I would really think when the biopsy was done. Suppose if she's primary steroid resistance, meaning one has given steroids for close to 8 weeks, or close to 12 weeks, and sometimes close to 16 weeks, and is presenting with MPGN, this is the case where one would send it for electron microscopy, because they would turn out to be either dense deposit disease, or they would turn out to be C3 kind of membranoproliferative GN, or maybe some immunotactoid nephropathy which is not responding to steroids, and which unfortunately might have a uniformly poor prognosis. The normal C3 always is a cause for concern. One has to see when it's been done. If he's got surreptitious or got steroid therapy initially, sometimes it may give you a false negative on the biopsy. And one sometimes will just have to wait and see if the C3s go down if you've stopped immunosuppression in this person, because in any case, he's not responding to steroid-resistant nephrotic syndrome. So I would strongly urge this particular child definitely requires electron microscopy to delineate his disease and decide. Sometimes when we didn't have an electron microscopy in our own unit, we tied up with Dr. Patrick Walker in at Arkansas, and he was grateful enough to do the biopsies free for us. Sometimes one can find out ways and means to get these things done. And we have a question. Can you explain why lupus tends to become quiescent when patients get to ESKD? Common question. So this is called the burnt out lupus. Very true. Lupus tends to quiesce once patients unfortunately land upon dialysis. But at the same time, I want to draw your attention to the two lupus which don't become quiescent. So cerebritis, lupus cerebritis, and lupus associated with lung diseases, they may not become quiescent even if patients land upon hemodialysis. But otherwise, it is thought that the antibodies, it's a clonal activation of immunoglobulins that occurs, and the kidneys somehow act as a sump for these antibodies, And that's one of the reasons that people feel. The other reason is sometimes people feel that some of these cytokines get dialyzed out. It could be anything. I don't have an easy answer to give you on this particular question, actually. Any preferences between ACE inhibitors and AR blockers? Yes, actually, this is a personal preference. I usually tend to start on very low dose of ramipril. Ramipril is one drug which gives us the lowest possible doses you could start. So 1.25 milligrams or 2.5 milligrams can be titrated in young children to young adults, and then slowly up titrated to the maximum tolerable dose, meaning either the creatinine starts moving or patients develop postural drops. That is the maximum titrable dose for ACE inhibitors or AR blockers. All patients who take them should be informed that they should stop these drugs in case they develop very severe diarrhea, vomiting, or they perspire huge amounts. In India, these are three real challenges and can precipitate acute kidney injury in all these patients. So I would at the same time urge all my colleagues to definitely, whenever you prescribe them, at the same time, one must inform this to all our patients. 2-3 days of not taking the drug is not going to harm anybody. How often have you encountered minimal change disease in adults? Approach to treatment in adults versus children. So minimal change disease in adults is rare as compared to adults. I have an observer bias because I am in a tertiary care center where we get a lot of these patients. All of the adults more than 14 years of age, we biopsy them. We rule out any other secondary causes of adult onset nephrotic syndrome like lupus nephritis, minimal change disease, before labeling them as having minimal change disease. They tend to require larger doses of steroids. They are less sensitive to steroids. They take longer time. They relapse faster. They become frustrated with doctors and medicines faster. I have, in my practice, usually used a very prolonged, slow taper of steroids in these people. So usually in pediatric age groups, I would, after 6 weeks of 2 mg per kg of steroid or 60 milligram per meter square body surface area of steroid, start tapering and bring them down to no steroids after, say, 1.5 to 2 months after the 6 weeks. But for the adults, it usually is a 4 or 5 month long process of attaining remission and then slow tapers for them. When should I suspect nephrotic syndrome due to causes in diabetic kidney disease? Another very relevant and very important question. You must suspect nephrotic syndrome in diabetic kidney disease whenever the amount of proteinuria is more than 3 grams per day, along with presence of significant amount of anasarca. And usual amount of proteinuria that you will get is around 6-8 grams per day. We have had multiple patients where we have had minimal change disease mimicking or coming along with diabetic kidney disease as one of the mimickers. Another place where you would suspect is where you have proteinuria. There is a history of long-standing diabetes. At the same time, retinopathy does not show diabetic changes, and you have nephrotic syndrome. So that's another. And lastly, this is rare. Always look out for complement depression in these people. So many of these diabetic patients we have seen with foot ulcers, and these are the places where staphylococcus or streptococcus triggers of presence of complement associated nephritic and nephrotic syndrome in these patients. So these are situations where you might also consider biopsying these patients. Can you comment in glomerular disease in diabetes apart from diabetic nephropathy? How so in diabetes, as I mentioned, this is in continuum to what was I saying earlier, is one will get complement associated glomerulonephritis. One should also think about paraproteinemias. The only way to differentiate paraproteinemia associated or amyloid associated glomerular nephropathy with diabetes, glomerular nephropathy, glomerulonephritis is a biopsy, where you'd get a Congo red positive with amyloid nephropathy, and you won't get it, or you'll get a KW lesion with diabetic nephropathy. Short of that, very difficult to differentiate between the two, both present with significant amount of proteinuria. So this is another situation where if one is suspecting amyloid, which could be secondary or primary, go ahead, must biopsy. Without a biopsy, you will not be able to really treat the patient appropriately. So any role for azathioprine in glomerular disease? Absolutely. In lupus nephritis, in maintenance regimens for ANCA vasculitis, azathioprine is one of the drugs which you could use for long time maintenance, and also to avoid as a part of steroid, what should I say, steroid avoidance. Because many of these patients will develop cataracts or hip arthritis that occurs, avascular necrosis. I commonly use azathioprine in my patients with lupus and ANCA vasculitis. So both are inflammatory disease, systemic diseases. Azathioprine, which is cheap, which can be given once a day. And I have made it a point to check them for TPMT levels prior to starting them with azathioprine, and write in extremely bold letters on their discharge summaries, they should not get allopurinol when they are on azathioprine. Any other antiproteinuric agents apart from ACE inhibitors and AR blockers? Absolutely, sir. One can utilize diltiazem as one of the antiproteinuric agents. Only thing is, dose of diltiazem used for antiproteinuric agent is typically 120 milligram onwards. So large doses, if the patients are hypertensive, it acts dually. It controls the hypertension and also decreases the proteinuria. The other two drugs are CNIs, that is tacrolimus and cyclosporin. They act by decreasing the GFR and also have some immunomodulatory characteristics, and they help in decreasing proteinuria, especially in patients who are steroid dependent, like steroid dependent nephrotic syndromes. So I use cyclosporin or tacrolimus in these situations where the proteinuria levels lead to patients getting malnourished. So this typically occurs in long-standing membranous nephropathy. And of late, class 5 lupus nephritis, which is also present with membranous nephropathy. And diltiazem I have not used very commonly as a part of antiproteinuric agent. So there is no... Oh,
yes,
sorry.
Yes, please. Yeah, proceed,
I think
please.
this is probably the last one. So there's no role for azathioprine in other GNs apart from lupus and ANCA. These are the ones that I utilize. There could be a role for azathioprine, more as a steroid avoidance drug, especially if patients are developing Cushingoid, phases, or they are having subcapsular cataracts, or they are developing avascular necrosis of hip, or myopathies, proximal myopathies. This is where probably azathioprine will help you use it as an alternative to steroids. But proven benefits, apart from lupus and ANCA, the evidence is not very strong.
All right. Thank you very much, Professor Abhijit. That was excellent presentation. You've been able to answer all the questions. There were more than 17 questions. Thank you very much. We really appreciate that. And I think you have come to an end of our presentation today. We really appreciate your time. I know it's very late there in India. And I would like to welcome Dr. Lloyd for final comments, and then we'll close. Dr. Lloyd?
Yeah, thank you, Abhijit. There was so much of interest, and I think it's good that again stopped, because the questions would have kept coming otherwise. Thank you. A wonderful presentation.
The pleasure was all mine.
Wonderful, and so much of things, so much of interest from the audience. And 18 questions. We've not had those many questions of recent actually, and we've gone for such a long time, and wonderfully that you've actually answered those questions so beautifully and very with so much of clarity, and I really appreciate that, and the depth of knowledge shows as well, and it's so nice to listen to the entire presentation at every stage of it. Thank you so much, Abhijit. It is such a pleasure, and we need you more for glomerular disease. I think I'm going to catch you every year, at least 1 or 2 talks, please. Just
sure,
to, I think it's very important that they know glomerular disease, and the depth and the clarity is extremely important. To identify, and biopsy is another very important thing that we don't have much here. We hopefully that we could actually project to see how we can do biopsies in these areas. Except of course, kidney is not a problem, but I think we do have problems in certain regions, certain other regions. Yes.
Right, sir.
Thank you so much. It's very late.
To the panelists and you, sir, and to Africa Health Network team.
Thank you so much. And we would appreciate a PDF of whatever slides you can spare. I'll send it across to everybody, especially the initial part. Yeah. Thank you. Thank you so much, Abhijit. Thank you very, very much. Thank you so much.
Thank you. Thank you. Thank you very much. Thank you.